بسم الله والصلاة والسلام على سيدنا محمد وعلى آله الطيبين الطاهرين وأصحابه المختارين. السلام عليكم ورحمة الله وبركاته. In this lecture, we are going to talk about monitoring during massive blood transfusion and massive obstetric hemorrhage. During postpartum hemorrhage, we are looking for the vital sign, the heart rate, the blood pressure, the significant cold extremities, the delirium of the patients. There is certain sign the physician he should concentrate on them. One of them is the pulse pressure. The pulse pressure is the difference between systolic blood pressure and diastolic blood pressure. And if this pulse pressure is between 30 and 40 millimeter mercury, we will consider it normal. If it is more than 60, we will consider it wide. And if it is less than 30, we will consider it narrow. And it's occur more in the hypovolemia and in postpartum hemorrhage, the patient in shock, cardiac tamponade. So the presence of the narrow pulse pressure indicated that this patient in real an emergency and need real resuscitation. Remember, when we talk about the shock index, and we are talking about the early shock, when the shock index, which is the systole, the heart rate divided by the systolic blood pressure, and we said that if the shock index less than 9, it is normal, well compensated, and if it's between 9 and 1.9, it is yellow, it's early shock. More than 1.3, significant shock, you should start requesting the blood. And if it's more than 1.5, it is severe shock, so you have to start the massive blood transfusion protocol 1:1:1. Profound shock, you have to shift the patient for surgical management because the patient life really in danger. We can use the inferior vena cava collapsibility index. What is the inferior vena cava collapsibility index? We are going to measure the inferior vena cava maximum and minimum, subtract maximum from minimum, divided by maximum, multiply by 100. Where to measure it? Measure it 2 centimeters distal to the hepatic vein, inferior vena cava junction. How we are going to use it? We are going to measure the inferior vena cava collapsibility index if inferior vena cava less than 2.1 centimeter with 50% collapse. That means there is hypovolemia, most likely. To measure the index, we are measuring it with the expiration, which is the maximum, and with inspiration, which is the minimum. Subtract them, divided by the expiration, multiplied by 100. If it's more than 50%, that means the collapsibility index more than 50. That means there is hypovolemia most likely. So you have to resuscitate your patient. And when we have the inferior vena cava more than 2, it means that the volume overload. And we measure it the same way, and it will be less than 50%. So what is the significance of this? Assume that you have patients, and the patient, you started giving her fluids, and you want to know if you are giving too much fluids or she need to be added fluid on her. Then you measure the inferior vena cava collapsibility index, or simply you measure the inferior vena cava, and if it is less than 2, that means it's hypovolemia. Less than 1, severe hypovolemia. More than 2.1, that means you are going toward overhydration of the patients. You don't want to develop the complication of pulmonary edema due to the overhydration of the patient. Reference, you can see the reference here, and what we are referring to, inferior vena cava max, it's mean maximum diameter during the end expiration. And remember your physiology during the expiration, that there will be distension of the veins, where during inspiration, increasing the thoracic and intra-abdominal pressure, and this will collapse the vein. High collapsibility index suggested if your vena cava is collapsed and the patient may be a fluid response and hypovolemia, where if it is high, that's mean there is overhydration of it. It is good indicator. All what you need is ultrasound, which is available in most of the labor room and most of the places where you are managing a patient. If you cannot measure or you don't know how to measure, you ask the help from your colleague, the ICU specialist. Usually they are using the collapsibility index much in the trauma case. Other modality is passive leg raise, which is PLR test. A reverse cell volume challenge that transiently increase the venous return and giving around 250 to 300 ml fluids. How it's work when we raise the leg 45 degree, shifting the blood from the lower limb into the abdomen into the heart, then this will increase the venous return in the heart and increase the preload, and this will increase consequently cardiac output and stroke volume. So what we are going to do, we are going to put the patients, first of all, 45 degree and measure the cardiac output stroke volume, which they are more accurate. But if you don't have such a machine, what you can do, you can measure the pulse pressure and measure the blood pressure. Then you put the patient flat and you raise the leg of the patient 45 degree. It's better to do raising of the leg by raising the bed, not manual raising of the leg. But unfortunately, in a lot of situations, in a lot of hospitals, we don't have a bed which you can raise and make the patient flat and raise the leg. In such a situation, you make the bed flat, then you raise the leg around 45 degree, and again you measure cardiac output, stroke volume, and if it's increasing by 15%, that means this test is positive, and it's mean the patient will benefit from more fluid resuscitation. The other modality is measuring the pulse pressure. If it's more than 10%, or blood pressure may increase modestly around also 10 to 15%. And all, either you do cardiac output stroke volume, or you measure pulse pressure and blood pressure together, and this will give you more accurate measure. Patients will likely benefit from IV fluid resuscitation and most probably hypovolemia contributing to instability of the patient. Important point, the PLR is reversible and the effect lasts only while the leg is raising. We take this as basic information when we are in medical school. When you see a patient with car accident and they have bleeding and you are suspecting they are in hypovolemia and still you are away from the emergency, raise their leg. Or when somebody fainted due to the hypotension, raise their leg. And this is what is behind it. And we can use this simple measure to decide if you need to increase the amount of fluid resuscitation. So we simplify it, the patient in the semi-recumbent position, 45 degree, then put the patient flat, raise the leg 45 degree, measure the pulse pressure. If it is more than 10%, that means it is passive leg raising and the patient will likely benefit from resuscitation. By the way, the pulse pressure, for the people who don't know how to measure it, it is systolic blood pressure minus the diastolic blood pressure. Simple test like this test, if you raise the leg 45 degree and there is no increase in the stroke volume, cardiac output, or pulse pressure remaining unchanged, this is telling you that additional of fluids is unlikely to improve the performance, so you have to consider the vasopressin, inotropes, or addressing other cause of shock. When you reach to this situation, it is better to have the ICU people with you, whether you can transfer the patient to the ICU or the ICU team will come to help you in resuscitating the patients. Early detection, timely intervention, better outcome, and we will end up by saving lives. So in summary, continuous monitoring during postpartum hemorrhage is mandatory, whether we are talking about monitoring of the clinical and hemodynamical parameter like vital sign, shock index, pulse pressure, collapsibility index, and passive leg raise. Look to the mental status, urine output, and blood loss. Continuously doing the investigation like hemoglobin, fibrinogen, PT, PTT, calcium, potassium, and ABG. And frequently reassessment of the patient. All of them, the goal of monitoring is to detect ongoing bleeding early, assessing tissue perfusion and organ function, and guide resuscitation and transfusion therapy, prevent complication of shock and organ failure, and improve mental survival and outcome. So monitoring continuously, act promptly, assist frequently, prevent organ failure, and save maternal life. I hope that you benefited from this lecture. Thank you. Thank you for your commitment to excellency in women healthcare. Together we are shaping safe care, improving outcome, and supporting every woman at every step.